Okay, hi everyone. Thank you so much for joining us today. We have a great webinar for you this morning, Getting Back to Business After COVID-19, Improving Infection Control and Conserving PPE by Treating One Patient at a Time with Seek, Treat, and Complete. My name is Monica Venley, and I'm the Marketing Manager here at Onpharma, and I'll be the moderator for our session today. Before I introduce our speakers, I'd like to just remind everyone that you're all automatically placed on mute, and this is a webinar format, so you won't be able to see your pictures. But if you'd like to submit any questions, you can use the chat function at the bottom or the Q&A function at the bottom of your screen in the Zoom menu to be able to submit a question. And then we'll go through those questions and select some that don't get answered during the conversation and have about 15 minutes at the end for Q&A. And now I'd like to introduce our two speakers. Dr. Mick Falkel is the co-founder and CMO of Onpharma Company, an anesthetic technology company. Since 1989, he has been in general practice in Monterey, California, and he also holds a position as assistant professor in local anesthesia at the University of the Pacific Arthur A. Dugoni School of Dentistry. Dr. Falkel is a well-known speaker on the topic of local anesthesia and has lectured at many national and regional dental meetings since 2011. And we also have with us today Cindy Ishimoto. Cindy is a practice management consultant with over 35 years of dental consulting and speaking experience. Cindy has worked in all specialties, small practices, very large group practices, with new practitioners and with those who are transitioning out of dentistry. Her focus is on helping practices establish systems that balance serving patients, profitability, and enjoyment of profession. She is well known for her expertise in the business for financial management, motivational, and team building systems for the practice. Without further ado, I'd like to go ahead and kick it over to Dr. Falkel to start our conversation.
Thanks, Monica. Well, and I want to thank everybody for being on the line today and spending a little bit of time with Cindy and I. Cindy and I have been close friends for a long time. I've worked with Cindy as my dental consultant for years, and I attribute a lot of, if not all of my success to Cindy and her great knowledge. So I'm excited to have her on the line with me today to help everybody understand some things that you may not have thought about, because we have so many things to think about as we get back to work in this new normal. So we're going to be talking about three main topics today: how the status quo has changed moving forward, how to operate efficiently and profitably in our practices in this new environment, and then how to use Seek, Treat, and Complete effectively as a new model moving forward. So with that, I'd like to say hi, Cindy, and thanks so much for joining us. Cindy is a truly dear friend, so thanks, Cindy.
Well, what a nice introduction, Mick. And yes, I have been working with Mick for quite a long time. I have enjoyed every minute and am thankful that he introduced me to things that moved my career forward also. So we have a great mutual respect for one another and a lot of love, absolutely. And, you know, I've been moving along through all of this with all of you, learning new things for sure, being asked, Cindy, will things ever go back to normal? And my answer is, what's normal? Nothing's normal. It wasn't even normal when we were doing what we were doing when we closed our doors. Each practice was unique. Each practice was different. This status quo piece about dentistry, Dr. Falkel, is there really a status quo? Because now, you know, everything's changed. That status quo means same thing over and over without change. Is that what you want? You want to keep it the way it was? That status quo keeps everyone in their comfort zone, right? That comfort zone is a place, it's home. It's home. When you're on the outside looking in, it may seem like back then was so much easier. Growth occurs for all of us when we step outside of our comfort zone and we stretch. And I know that our old habits can prevent us from changing. It slows us down. It keeps us paralyzed, sort of daydreaming about what used to be and not wanting to change. We need to change so we can thrive. This uncertainty, inertia, holding on to that dream leads to paralysis. It prevents changing. It prevents processes. It keeps you from planning, and certainly it will lead you to chaos in your future. Things already changed. They're not going back to normal. It doesn't exist. The new normal, it's right in front of us. It's important that we focus on it and we know what we need to change within our businesses, within adapting and being flexible so that we can bring on what we need to bring on to take care of our staff, to take care of ourselves, and to take care of our patients. So today, I think that let's take that status quo thought and let's move it to the rear. Let's move it out of our sight pattern. Let's take it off our comfort zone table, and let's think about what things can we do in our practices to have things be efficient and effective and meet our service models. What do you think about that, Dr. Falkel?
Well, I think you're absolutely right. The status quo is changed. It's something in our rearview mirror, and you know, there's quite a few things of the status quo that are definitely in our rearview mirror. So, what would you say the primary things that are in our rearview mirror with respect to status quo right now?
Well, that rear view mirror shows me that if you haven't been working on your scheduling system before you open, you're in trouble. That's gonna change and dynamically change. And it's gonna dynamically change because everything you need to do in that operatory has changed to prepare for the procedure. So the scheduling system is, for me, a little bit of a heartbeat challenge, gives me palpitations, I guess, because that's kind of my part in dentistry, is to help guide you through what that may be. There's other things that have changed. We all know that, you know, we've got more PPE, we've got more garb to wear, we've got to learn how to do the procedure with all of that on, so that takes time. We have a new way of having to speak to our patients. We're going to have to go through all this process to help them understand exactly what we're doing and why we're doing it. Everything we do adds time to our scheduling. It adds time. And in time, that's where our profitability is. That's the only thing we own, is our time. And for that, we have to figure out how to make that work for everyone and continue to be profitable so we can continue to care for our patients. I think actually, Mick, what's totally in the rear view mirror is the era of op to op hopping. I think that may be over for dentistry. We need to look at a new way of being able to go into the treatment room, sit down, be with our patients, deliver the treatment, complete it, and then leave. Because this op-to-op hopping we've done in the history has it will be very costly in many ways now. So I think, number one, that op-to-op hopping, we got to figure that one out.
Well, I think you're absolutely right. I think that, you know, you brought up PPE, and that's big on everybody's mind right now. Right. You know, we're going to have to put on so many more things than we did in the future. You also brought up earlier, you know, is this going to go back to normal? And I think you're absolutely right. It's not going to go back to normal. You know, when it comes to PPE, I've been telling people that, you know, when I started dental school, I was the very first class at the University of the Pacific that had to wear universal precautions. And that at that time was eyeglasses or eye protection, a mask, and gloves. So prior to that, you didn't have to wear any of that. So I was a class of 87. So in the class of 86, you did not have to wear that. And before, the reason it changed was because of the AIDS epidemic. And that had started, and I was in San Francisco in dental school where, you know, it was kind of the epicenter of AIDS. And I had professors saying, oh, don't worry, in a year or two, we'll be back to going in there with our bare hands and not having to wear a mask and all of these things. So just don't get too used to it. Well, 35 years later, here we are still wearing universal precautions up until 6 or 8 weeks ago.
Right.
Flash forward to now, we're understanding that we have to wear a lot more.
Right.
Head covering, face shield, N95 respirator, or at least a level 3 mask, disposable or some sort of surgical gown, maybe even feet covering. And we're going to have to don and doff that properly, which is a difficult, timely piece of thing that we haven't had to do in the past. And in doffing it, we have to take it all off before we've left the room and move on. At least that's the way I interpret the CDC recommendations, if you will. And so you're absolutely right. Jumping from room to room to room, bopping in and out is a habit that we have to dispense of. And you and I have been working on that for a long time prior to this for an efficiency model that I don't think people really felt they needed a solution to this problem of jumping from room to room. You and I figured out that you could be so much more efficient from a scheduling point of view, and we'll talk about that. But Seat, Treat, and Complete is going to be able to give us the opportunity to seat one patient, give them our complete attention, treat them, and then complete the process and move on, so that we don't have to go from room to room anymore, and we can keep the patient volume up and run a business as well. So not only conserving on PPEs, but also conserving on efficiency and being able to run a business that is completely new to us. This is all new territory.
Absolutely. I think also that this piece about not moving back and forth in operatories all the time, this cross-contamination issue, we have to find a way to decrease it. That's the fear of our patients, right? Is that they're going to come into an environment where it's going to be all around them.
Yeah, actually, if you're moving from room to room, the dentist becomes the vector of cross-contamination. And patients are going to be watching now. It's interesting when it comes to PPE, 8 weeks ago, nobody knew about that except those of us in the healthcare profession. And even those of us weren't that educated on it. Well, now everybody has got a PhD because they've been sitting at home watching TV, and everybody's talking about PPE over the last 6 to 8 weeks. So now our patients are going to actually be looking for things that we may be doing right, hopefully, and they may be looking for things that we may be doing wrong, which is unfortunate. So, I think having the ability to seat, treat, and complete is going to be really paramount. So what do you think about seat, treat, and complete? Do you think that's something that that dentists will grasp?
What I find normally is that this history was that because they had time in that first 10 to 12 minutes after they deliver an anesthesia to go do something else. They had time, and time is money. And in that time, we stuck in lots of things, usually more than 10 to 12 minutes of things. We certainly went to do hygiene exams. We leave the room and we'd start another patient, or we'd disappear into our private offices and play with our computers, or we get stuck in a hallway with our business team talking. So that model, that huge model, was because of that window of anesthesia latency. It was, period. And we developed a whole scheduling routine, a whole service model, a patient care model that involved what to do with that time. And we stepped out of that room, and think about this one, Nick. Our dental assistants stepped out too. I just saw dollar signs flashing before my eyes for my PPE, thinking that 2 people have now left the room. And it wasn't 10 to 12 minutes. It was for anesthesia because that's when we needed to know. But the doctor showed up sometimes 15 minutes later, 20 minutes later. And in that, time was ticking away. And we were running our schedules late. We were keeping our patients waiting. Whatever it was that we thought we were accomplished actually had the reverse effect. Where now, if we seat the patient, do not leave. If we use buffered anesthetic, and we can have anesthesia in 2 minutes, now we can go, go, go. And in the go, 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 in time and motion, remember that an object in motion continues to be in motion. We don't want the transitions because the transitions are brain killers and time killers. We have to focus, refocus, and then the PPE costs go up. So if we can give anesthesia, have profound anesthesia in 2 minutes, and get going, we already have saved a 10-minute window. And we save for ourselves. So how about back when we first started doing Seat, Treat, and Complete with you? What happened to you?
Well, I'll tell you, first of all, for those of you that don't know buffered anesthetic, we'll take a little step back and talk about that for a second. I started working on buffered anesthetic about 18 years ago. I had a little family crisis, a big family crisis, and I just needed something else to think about in my time. And I was a chemist before I was a dentist, so I started thinking about how could I make local anesthetic better for me? And my big problems with local anesthetic were, number one, I was taught that if you gave a painless injection, you could build a whole practice around that. And I worked really hard on my technique. UOP taught us great technique. And I kind of got known in town as being the guy who gave the most comfortable injection, and it did build my practice. But it bothered me that I still had patients that as soon as the anesthetic would start to go in, so I could fool them getting the needle in, but they would wince. And some of those people felt that that was exquisite pain. And I realized that that was a chemical problem of the acidity of the anesthetic, not a technique problem. So I wanted to see if we could fix that. And then I also hated local anesthetic failure. You know, when local anesthetic failed, I took it personally because I thought it was my fault. I thought I was doing it incorrectly. It turns out that's not the case. It's actually the patient's fault because they have to buffer the anesthetic when we put it in. And on any given day, any given patient may not be able to do that. And so anesthetic fails. Now, when we come back to the new normal and anesthetic fails, boy, you've really got a problem. If you're doing a mandibular block and you've got 15 minutes invested so far and now they're not numb, and you've got to re-inject, now you've got another 10 or 15 minutes to wait. So that's something that really is a problem now. And then the last thing was I'm kind of an efficiency guy. That's how you and I got together. And I really hated in my own practice, giving anesthetic and going and finding something else to do while the patient marinates and hopefully gets numb. I didn't like running from room to room to room. So with buffered anesthetic, we put sodium bicarbonate into the anesthetic cartridge, deliver the cartridge of anesthetic immediately after it's buffered, and now you get all of those benefits. An injection that is comfortable not only from a technique point of view, but also from a chemical point of view. You're going to have dramatically less failure. When you do fail, you'll know right away and can correct. And because it's not going to help you put it in the right spot, but it's going to let you know right away if you haven't put it in the right spot. And then most importantly, with what we're talking about today, is it gives you the opportunity to seat, treat, and complete. So I remember when I had you in my office, I was working on buffered anesthetic and you were watching me work. Why don't you talk about that a little bit?
That was my introduction. The introduction to actually a life-altering moment for me in dentistry. It was life-altering. I said that to you because I watched him do something. He refused to tell me what he was going to be doing. He said, you just watch all day. We'll talk about it at the end of the day. Well, I'm sure you get the message that telling me not to talk is not a good thing. And so what he did, he went in and he was playing with something. He was doing something. I couldn't see it. I just couldn't see what he was doing. And then I saw him give anesthetic. I listened to him chat up his patient for a really short period of time, like super short. He asked a couple of anesthetic questions like, how are you feeling? Is it numb? Are you tingly? Patient said yes, and he picked up his handpiece and he went. And inside, my heart was going like this because I kept thinking, oh my God, he's going to create a jumper. Oh my God, they're going to be jumping all over the chair. That patient never moved, and never afterwards did I hear from a patient when he asked the question, how'd the procedure go? Did they say, well, I sort of felt it, but I didn't want to stop you. I never heard that. The next patient repeated. The next patient, the whole day went like this. And I kept wondering, how can this dentist be accomplishing this? The shock was the mandibular block for me. It made me drop my jaw and say, oh my God, aren't you going to run away to another operatory? Go check your hygiene? Aren't you going to go do that? He just smiled at me and he said, end of the day, Cindy, end of the day. And at the end of the day, he told me about what this was and what he was creating and using, and where he thought it might go in dentistry. In dentistry, all I could imagine was, oh my gosh, I have to fix everybody's schedule. I have work to do. And for the last 10 years, since Onset came to market, we have, you and I, have been working on how to teach people what a joy it is, a pure joy it is to do seat, treat, and complete. And why is that joy there for you, Nick? That there's a piece that you haven't talked about that jumping from op to op. What was it for you when we changed your schedule?
Well, I'll tell you that the first thing you told me is at the end of that day, you said, look, I can take what you're doing and teach you how to save an hour to 2 hours a day. And I said, wow, that's great, Cindy. But you know, what I'm looking for is days off, not necessarily 1 or 2 more days. So you took my schedule, which I mean, you're the practice management consultant. I've always considered my practice pretty busy and very productive. And so it was a 4-day schedule. And you showed me with scheduling around what we now call seat, treat, and complete. At that time, we called it stay with the patient. And with that paradigm, you showed me how to bring that 4-day schedule down to 2.5 days. And at 2.5 days, I would put my production up against almost anybody's in general dentistry. And my stress went down. And my patients liked it better. One interesting thing I found was, you know, patients would say, he spent more time with me, when actually I was spending 30% less time with them. But what it was without running in and out of the room, they felt like it was more quality time. And so actually the experience of the patient was better. So, you know, what I was looking for in dentistry is to solve the problems around local anesthetic that could lead to a better patient experience, a more efficient model, and a business model that allowed dentists to be as productive and profitable as possible. Because you're dramatically reducing your overhead if you're doing the same amount of work in less time. And so with that, I attribute all of that scheduling to you. And we've worked really hard in the past to try to convince dentists, and I know you have when you work closely with them, but you know, dentists were so used to jumping from room to room to room that it's a very hard habit to break. And I think we were trying to solve a problem that most dentists didn't really want solved, but now they need to have it solved. We need a solution to that. And so what's great about Seat, Treat, and Complete is we've got 10 years of not just myself, but a lot of dentists. I'm literally hundreds, maybe 1,000 dentists that have been doing this all along for a different reason than why we need to do it moving forward. So it works. It gives us the ability to stay with the patient. It will dramatically reduce the amount of PPE use. I know in my particular practice, you know, when we open up, hopefully in the next week or two, one of the primary gauges of whether or not we can open up is, do we have enough PPE equipment?
Right.
Let alone how much it costs, right? You know, it's triple, quadruple. People are gouging on these, on all of this equipment. So the expense of it is ridiculous, but do we have enough to get back to work and stay back at work?
Right.
And so anything we can do to reduce that PPE usage is going to be a dramatic increase for the practice and the ability to just stay open. So learning how to sit down, have a patient seated, give them anesthetic, go right to work. By the way, you taught me that time and motion study shows that not only are you saving the injection wait time or anesthetic latency time, but you're also 30% more effective if you're uninterrupted. That's just time and motion studies. And you've proven that to me. We wrote a paper about it. And it's totally true. I mean, I like to give the example, you know, I write a lot and I can't write at home because I've got kids and they interrupt me. Dad, I need this, do this, that, you know, and it takes me forever to finish the product. But if I come to the office and I'm completely uninterrupted, the writing goes very quickly. Well, dentistry is just a task, just like writing or just like anything. And if you're uninterrupted, you're 30% more efficient. I think that you've shown that certainly to me, and it is absolutely the fact, because you can't take a practice from 4 days a week to 2.5 days a week just on removing anesthetic latency time. It's staying with the patient and being uninterrupted that gives you all of that extra time. And so as we move back into this new normal, I think that this is an opportunity for dentists to grasp that concept and put it to work and be better than they were before. Less stress, less cost, lower overhead, same patient volume, and a business that thrives in a new normal that all of us are trying to figure that out. So, you know, thank you so much for helping me that, right, for recognizing it right from the very moment, you know, that I was working on it. And now 10 years later, we have a better use for it than we ever did.
I think all of your comments, right, all of this piece of utilizing buffered anesthetic is all this win-win-win piece where we've been hearing with everything post-COVID, it's lose, lose, lose for us, right? Lose more money. The insurance companies won't pay you. Invest in everything you need to lift yourself to the new guidelines. Well, the new guidelines aren't even cast in stone and we're investing money. Doctors are spending more money, more money, more money. And this one tweak, as it be, to a system of dentistry can actually make a better day for you, along with patients receiving buffered anesthetic and thinking you're a god because you're not hurting them. There is multiple things that Seat, Treat, and Complete does for your practice. And scheduling it, all we need to switch is a frame of mind. Well, that's the most stubborn part in the word change, right? Is frame of mind.
Are you saying that dentists are stubborn?
No, I'm saying we all are. No one likes to change, right? No one likes to change. And you have habitual movement. And the habitual movement is that your body is already trained to give anesthetic, pat your patient on the shoulder and say, I'll be right back. And you leave. Well, that's going to be this part about almost needing to glue yourself to the chair, because that's a dramatic change for dentists. And in that change, we have to look at a whole different scheduling model. That first 10 minutes of every appointment, you can't be thinking I'm going to go somewhere else, because if you think you're going somewhere else, think about costs rising, because PPE change is PPE change no matter where the guideline is. It's just PPE change, and that's this. It's also time. And I'm certainly concerned that we have dental assistants that are habitual also. So we're going to see people having trouble sitting and completing this. The gain is so dramatic. It's worth the investment to teach ourselves this new version of scheduling instead of scheduling to that loss of that 10 minutes. It's worth the investment. One of the other things that there's a couple of other things that we found along our lovely path together. One of them was The ability to treat a hygiene patient the day of in diagnosis was that. And the other one was that with case presentation, there might have been a period of time where you didn't like to numb up the mouth, the entire mouth. And so you would limit your treatment or your appointment to maybe 1 crown here and 1 crown there, but not all over the mouth. And this anesthetic technique allowed for some pieces that made the use of it even more positive. So I'd love to hear what it is you were doing with your hygienist. I'd love to hear about the fact that you can do more than you used to because of this anesthetic. And I'm sure the people on here would like to hear that too.
Oh, great, yeah. So with hygiene, you know, and I'm going to preface this with, you know, most people are, I believe most dental offices are going to be charging a, let's call it an infection control fee, if you will, or a PPE charge, you know, some amount of money that each appointment, just to defer some of the costs. It won't defer all of the costs, but it'll defer some of the costs. But that's a new charge for patients. And we're going to have to come up with verbal skills to be able to implement those charges and have patients understand why we're doing that. But when a patient is in the hygiene chair, you know, most of my patients are fairly well restored. Maybe they have a broken filling, a small cavity, something like that. That's all they have. Well, the norm is to say, okay, go make an appointment for that and come back on another day for 20, 30, 40 minutes, whatever you normally schedule for that. And that big hunk of time isn't the procedure, it's everything that's associated with the procedure, a lot of which is anesthetic time. And so what I started doing is whenever that came up in my hygiene schedule, I would say, would you like me to fix that today? Or do you want me to ruin another day? And that was what I used to say. And still to this day, 10 years later, I'm 100% success with people say, no, please don't ruin another day. Let's do it today. Well, I always like that because, you know, if you just have a single filling, patient may not feel that invested in needing to get it fixed. If it's, you know, they have a haircut appointment, that may take precedence over it or anything else. So you had a lot of failure of those appointments.
Right.
But if the patient's there and you give them anesthetic and do it today, the chance of them failing the appointment, I'm pretty sure, I don't like to do math in public, is 0%.
Yeah.
And so you can absolutely get the procedure done. Well, now, not only will you be able to say, and we won't ruin another day, but there won't be another infection control fee.
Right.
And now people will want that done right away. And if you do that 1 or 2 times a day, or even 2 or 3 times a week, the cost of a lot of these things goes out the window. You don't have to worry about that anymore because those are things that's just added production for that day. And you can never get back today what you do tomorrow. So you have that for it. So that's a great way to help your practice and help your patients. Also, another thing we need to think about is the less time a patient is in your office and the less times a patient is in your office, the less opportunity they have for infection.
Right.
Okay, so they're thinking about that as well. I want to get out of here and not have to come back. So that's a great thing when it comes to the hygiene appointment. With respect to treating multiple procedures in the same appointment, you know, I like to get as much done as I can. And I find patients would prefer to come in as few times as they can. And if you give anesthetic in one quadrant and finish your job, and then you can start in another quadrant, it's very easy with buffered anesthetic. If you don't have buffered anesthetic, you're trying to time, when am I giving anesthetic next, and so forth. It becomes difficult. And sometimes you're giving anesthetic too soon. Now it's wearing off. You have all of these problems that are associated with longer, more involved appointments that you can manage much easier with buffered anesthetic because you can give the anesthetic and go to work right away. You're not trying to time it into the other things that you're doing within that appointment. And again, you're going to see patients less often if you're treating them more comprehensively. Those appointments are always more productive. And if we can make that as efficient as possible, the business aspect of dentistry takes care of itself in this new normal, which is an opportunity that we all have to try to explore, because we need to have the businesses not only running, but running profitably, or we can't run a business that's not profitable. So I think that buffered anesthetic helps dramatically with that as well.
I think the true efficiency and effectiveness model, which is the game, right? The name of the game is to be really efficient with our time and effective with it. How do we serve that patient? How do we keep them from having to invest more time? And we're talking about conservation of PPE. And in that, we need to look at that whole segment of anesthesia. And one of the things that was certainly not true when we first met, because you didn't have that cartridge pen. You didn't have what Onset offers for the ease of buffering anesthetic. You didn't have it. It was an interesting look at how you were buffering at that time. However, right now, one of the things that really makes me pleased for dentists to be able to use this is that it can be done chairside, it can be done quickly, and there's once again, we meet the efficiency and effectiveness model. So I love that cartridge. I'm wondering about what you could offer our audience today about how quick that is.
Sure. Well, so the process for buffering local anesthetic is pretty straightforward and pretty easy. What we've done is we've put together something we call the Onset pen, and we're going to use our existing cartridges of local anesthetic, which, by the way, turns out to be the ideal perfect mixing vessel for mixing sodium bicarbonate, which is our body's buffer, into the cartridge of anesthetic to essentially supercharge the anesthetic so that it works right away, is very comfortable, and we have less failure. And it's very easy to do. The nice thing about buffering with Onset is that you can use all of your anesthetic. So whatever your favorite anesthetic cartridge is, you can buffer that cartridge of anesthetic. When you're ready to buffer the cartridge, and that is right before you give the injection, you want to buffer the cartridge, have the assistant place the cartridge into the syringe, and then you're ready to give the injection. Matter of fact, I'm already in the mouth. And the reason for that is the smoother that transition is and the quicker that transition is, the better it works. And so if you watch, I'll just really quickly buffer a cartridge of anesthetic. You push the cartridge in, turn this little nozzle, push it together like that, and then you dial the dose. There's a dial here that's a volume dial. We dial 9 on this little volume dial, push the button, and then reverse the steps. And now you place that into the cartridge or into your syringe, and you're ready to go. So even demonstrating that was maybe 5 seconds. Your assistants can get that down. My assistants, you know, they race each other. It's a second or two. So in order to get those benefits of See, Treat, and Complete, one of the investments you have to make is an investment of 3 to 5 seconds to buffer your cartridge of anesthetic. Once that cartridge is buffered, it's placed in the syringe. You give your anesthetic with the same techniques. There's no need to learn any new techniques. I personally don't even use topical anesthetic anymore. I don't really find the need for it. It's one less thing to do. And I find when you put something that tastes nasty in somebody's mouth, they salivate like crazy. So without using topical anesthetic, it makes a difference as well. So you save that expense, but you also save that time of placing the topical anesthetic.
That cartridge pen, where was that when you first started? Because
that was behind my sleeve. That was up my sleeve, so you couldn't see it.
Aha, okay, because truly the savings here, the piece here that is clear to me is the efficiency piece. That's a super efficient process. And it's dental assistant driven, which means they prepare it for you, and you got your hand ready to be past your anesthetic, ready to go, and you're in the mouth. So See, Treat, and Complete, the reality of it, including the buffering, is the time goes like this. And it's over. And the patient's numb, and 2 minutes later, you're off treating this patient. And That whole study we did with you, we took things from 50 minutes down to 30 minutes with you. You had 30 minutes of doctor time. We still had dental assistant time. We still had things, the operatory was still occupied. There was still breakdown and setup. There was all that. However, you appeared to get faster. I don't know that your hands were faster. It was the efficiency piece of staying in the room. Is that right?
Absolutely. Yeah. And not being interrupted.
Right.
You know, being able to sit down, start the procedure, complete the procedure, move on to the next person. You know, seeing your patient only one time actually makes it a better experience for them. Now it's a safer experience.
Right.
You know, really, we can't underestimate how safe, how important safety is, and that patients will be looking for safety, and you can market to safety.
Right. What a great piece. I think that so many people have asked me, how are we going to continue to serve our patient base and be productive? How are we going to be able to do what we did historically? Well, we can. We can. We have to change one piece. We have to move to a seek, treat, and complete model. And so that's, to me, the most valuable piece of what we've been talking about today is the fact that we can give back to these practices the ability to remain productive, decrease their costs with PPE, and decrease the cross-contamination piece. There's all kinds of things that are win-win-win. I'm really proud of what this offers, and actually I'm really proud to know my chemist, and to know and trust and believe that Onset and Onpharma has been a trusted friend and truly a trusted company to provide this for dentistry. And dentistry needs to embrace it right now and move to seek, treat, and complete. What do you think, Nick?
I think that's awesome, Cindy. I think you're absolutely right. I think in order to seek, treat, and complete, dental offices and dentists will have to make some investment. And
Yes.
that investment's going to be about $12 a day for all the anesthetic. It's about 3 to 5 seconds to buffer each cartridge of anesthetic. That's a small investment. And then probably the biggest investment is investing in changing a habit of bopping around the office and living by seek, treat, and complete, and getting all the benefits we talked about today. So thank you so much. I just hope this was as helpful as I think it may be for a lot of practices that are listening. And I'm excited to get back to work. And I'm excited that dentists will be able to get back to work in a manner that's safer, more effective, more profitable, less stressful. And all of that came out of COVID. And I just want to make sure everybody gets the opportunity to practice the profession that they love and went into. So I want to thank everybody. I think we're going to have some questions. So thank you, Cindy, for joining us. Monica's going to come on with some questions now.
Yes, yes. Thank you, Cindy, and thanks, Dr. Falkel. We've got a lot of wonderful questions. I have answered some of them that were just, sort of basic questions about the system. So folks, you can see all of those there in the Q&A panel. One question I did think that we should speak to, though. So how does seek, treat, and complete save on PPE usage exactly? How much will it save on a schedule, for instance, when there are 12 procedures on the schedule?
Cindy, you want to take that?
I don't have a dollar answer for you, doctors. We don't even know what it's costing us to buy it, because every time we go and purchase a new, hopefully we get N95 masks, right? Every time we go to purchase something, someone else is gouging us. What we know is that you'll have a 50% savings in PPE if you'll stay and seek and treat for each patient. What we know. And we know that because y'all were leaving at the 10 to 12 minute, gotta marinate your patient mark, and you had to change a certain amount of your PPE out. And now, depending on where we all land in this with the CDC, we might have gown change, especially if we've done anything that has penetrated the gowns. And so this piece of it is that every time you walk out the door, you're going to have to take things off. And you're going to need to see the dollar signs every time you take a set of gloves off and drop it in the bin, what that cost you. Every time you leave the treatment room, doctors, that face shield does not get to move with you, because that shield is now contaminated with that patient. And so we know that this is going to save you about 50%. We also know, think about the time, doctors. Think about the time and consumption it is to disrobe, to pull off all of those things and remember to take off what doesn't belong in someone else's operatory. So I think that that's the point that we need to be at. I wish we could tell you that dollar amount. I really wish I could tell you exactly what the dollar figure is, because I know that's a valuable answer. And when we stabilize with prices, yes, we could give you an answer. But at this moment, no, don't have one.
Okay,
Well,
thank you.
let me just add something real quick, Monica. I had a conversation yesterday with Rella Christensen. You know, and Rella, I think most people respect as kind of the go-to person with respect to infection control and many things in dentistry, but certainly infection control. And I asked her specifically because, you know, interpreting the guidelines by the CDC is an interpretation. And so in my practice, I want to know, when I leave the operatory, or my assistant leaves the operatory, or the hygienist leaves the operatory, what are we to do? And she said, you have to either dispose of all of the PPE equipment before you leave the operatory, or if it's washable, you have to put it in a special container, and then that gets washed either professionally or at the office. And you need to reinvest in another set of PPE before you go into the next appointment, along with proper washing your hands and so forth. So you know, it's not my interpretation, that's Rella's interpretation. So if you look at that and you leave the room just once and come back, there's your 50% savings.
Right.
That's great. That's great. Thank you, Mick. A couple of other questions about the system itself. Number one is, how do you manage the pens, the mixing pen itself, for infection control? And then also, in terms of using the system itself, do you need to use less anesthetic, or how many cartridges of anesthetic with the buffered once it's buffered do you typically use on a mandibular block?
Okay, well, I'll take that question. That's okay. With the pen is almost exactly the same size as a slow speed handpiece. So, you know, we have barriers for our slow speed handpiece. And you can put your pen directly into that barrier. And then when you poke the anesthetic cartridge right through, you just use it as normal. And now you're using the barrier technique like you would on your light handle or anything else. And then when that comes out of the room, the barrier comes off and you bring it into the next room by putting it into a barrier. So that's your infection control piece. With respect to the amount of anesthetic that you need, a buffering anesthetic does make anesthetic more efficient. So you may notice that you need less volume. You know, in mandibular block, I was taught that you 2 cartridges for mandibular block. I don't give 2 cartridges anymore. I give 1 cartridge, and I start pulp testing right away with cold, using endo ice on a cotton pledget, and I just start putting that on the teeth. As soon as they lose sensation to that, that is pulpal anesthesia, and you're ready to go. You will not have people that jump. Occasionally, I've missed, or I've been far enough away that I don't have complete anesthesia. I may have soft tissue anesthesia, but I don't have pulpal anesthesia. I give another injection in a new location. What I like to say is a little higher, a little lower, a little east, a little west, not the same location. And then within 2 minutes, I'm always started. So now maybe 5 or 10% of the time I'm giving 2 cartridges where it used to be 2 cartridges just started.
Okay. Okay. Thank you, Mick. That's great. And then I have another question. We've gotten several more questions about going back to hygiene and how you do your hygiene checks now that you're doing seat, treat, and complete and you're not getting up. One question specifically says, before you start the long procedure and then the next patient, do you check your hygiene at the end of their hygiene patient, or let's see, I'm sorry, or teledentistry with the hygiene collecting images. Sorry, that question's not.
I can take that actually. So I think I know where they're going with it. So
Okay,
let me
okay.
help. So when do you check the hygiene patient, and then how does teledentistry apply to hygiene?
Right, there we go.
So let me look at it that way. And what Cindy taught me was, number one, I am not checking my hygiene. I am doing an exam. And I can do that exam from the moment they're seated until they've exited. And so any time in there, I'm going to go in and see my patient. It's not checking hygiene. My hygienists do a fantastic job. They do a better job than me. That's why I hire them. And so I'm going in to examine the patient. So I'm conscious between patients that if there's a hygiene patient that I haven't seen, that's when I see them. And sometimes that's at the first moment of the appointment, and sometimes it's the very last moment. Anywhere in between, I'm willing to go in. So that answers that question from my side. With teledentistry, I've read a paper that some people are saying, maybe hygiene exams we don't do anymore. The hygienist collects data, whether that be films, probings, intraoral photography, and then we look at those afterwards and then call the patient and do a discussion through the exam. That's certainly people's object. If that works out great for them, that may be another savings of PPE. So you're not putting on another set of PPE. That remains to be seen. So I don't know that buffering anesthetic would save on teledentistry, but it certainly saves otherwise. And when you see your hygiene patient, you just see them whenever you're ready for them. And Cindy, that's what my take home message from you. Would you add anything to that?
I think that initial piece of when you do hygiene exams and when you break away, remember that it's a target. Okay, it's a target, and it's a window of opportunity for you to examine your patient. And the window needs to be as large as possible for a doctor to have success. And when we narrow that window down to the final 10 minutes of the hygiene visit, which historically has been what dentists have done, we run the hygiene patient behind schedule. We don't do as complete of an exam because we're worried about time. And so now if we look at it from there, when can we do the opportunity? If you've got 50 minutes of hygiene or 60 minutes of procedure time with a hygienist, that's a pretty big window. Now, many hygienists don't want you coming in there until they've gathered all the x-rays and the photos, etc. I don't stand there. I stand with Mick. Because if something comes up, I'd rather go back. I'd rather look at it on my screen in my operatory and do it. So the goal is give the doctor as much time as possible to have a window of opportunity to come and do their exam. There's some things about teledentistry that stand against being able to do a hygiene exam process and charge for it if you do teledentistry. Because the periodic exam by code says you looked in the mouth. And so that code itself would mean that you would have to drop that code. And the purpose of teledentistry wasn't to be that visual exam. So I do not know where this is going to go or what's going to happen. I know that it's a challenge. I'd rather see you figure out how to make this work. You've got the time in your schedule. You can get in there in that window of opportunity, which is what was successful for Mick. And the reason it was successful was also the opportunity to do same-day dentistry. So to me, the goal is to be able to do, to help our patients by seeing them and doing same-day dentistry. So that's my 2 cents.
The only thing I would add to that, because that's perfect, Cindy, the only thing I would add is, if I go into if that window of opportunity is the very beginning of the appointment, then I'm doing the exam, and certainly the hygienist is going to collect some data after I've left. Let's say it's x-rays. Well, I've already done my exam. I can now look at those x-rays and call the patient at the end of the day. That teledentistry, there's no charge to that. Right. That's just following up. But that mitigates the problem of showing up in the beginning and having the hygienist be frustrated because they hadn't done what they needed to do to gather the data. And I find that when I do that, my hygienists are happy and my patients are happy as well. And I do agree, if you, if you're in a hygiene room and you have a larger opportunity to be with the patient because you're between patients, then that leads to more acceptance of treatment because you have the additional time to spend with them. Then you move to the next patient, give them anesthetic, seat, treat, and complete.
Right on.
That's awesome. Thank you so much, Dr. Falkel and Cindy. I want to be appreciative of everyone's time. To wrap up, I'm going to go ahead and toss it over to our Director of Strategic Partnerships, Chris Webb, and he's going to just give you guys a little bit more information about how you can order Onset and where to get some additional questions answered if you need to.
Yeah, thanks, Monica. And we sincerely appreciate Cindy and Dr. Falkel covering, as we know, there's a lot of challenges as offices are looking to reopen. So a couple of follow-up items from us. First of all, I want to let you know that we will follow up an email to all of the folks registered. We had over 450 registered for our webinar. We'll send you a follow-up email that's going to have a link to Cindy's white paper, which is excellent. And also there will be a link to this webinar that you can review for yourself and also pass on to any of your colleagues. In addition to that, some of you may be interested in purchasing Onset, or you may be interested in getting more information. There's a couple of ways to do that. First of all, we love our distributor partners. We distribute Onset through Patterson, through Benco, and through Atlanta Dental. So you can reach out to your local representative and they would love to help you and support you. In addition to that, if you happen to order from someone else, you can also contact us 3 ways. One is you can visit onpharma.com. We'd love to help you there through our website. You can purchase directly or ask questions. You can also send us an email. That email is sales@onpharma.com. And finally, please feel free to give us a call at 1-877-336-6738. I will tell you that we have a 120-day money-back guarantee on the Onset mixing pen. That will allow you to get Onset, get trained. We do a 15-minute training webinar, and you can try buffered anesthetic with Onset 80 times within your practice. And if you decide it's not for you, we have a money-back guarantee on the mixing pen. So we would love to help you guys and love to support you. Even if you just have questions, please give us a call. So thank you very much.
Thank you all so much. We hope you enjoyed our webinar, and we hope to hear from you soon and answer any more questions. And please look for that email follow-up from us. Thank you, guys.
Thanks, everybody.